conductive system pacing. But the crucial point is here that I can finish my presentation with the last two slides from Professor Lamia, that left bundle area pacing is an alternative to the CRT. It's not a replacement. So when I fail with the CRT implantation, I can go directly with the left bundle area pacing, and this is actually what we do and what's the guideline state. So my first slide is very important. To believe without evidence and demonstration is an act of ignorance and folly. So we cannot use anything without a strong body of evidence. A heritage of years of 20,000 or more patients with the CRT prove that the CRT is very effective in the patients with heart failure to prevent mortality, decreasing hospitalization. And up to this point, up to the point I'm talking to you with, that we know that electrical dyssynchrony is prevalent in about 35% of the more advanced heart failure patient. And the CRT is the only class 1 indication in this patient to correct the dyssynchrony up to this point. And we know that left bundle carries a risk of worse prognosis in comparison with the patient with non-left bundle, and the wider the QRS complex, the worse is the patient in comparison to the narrower QRS complex with the same ejection fraction. And this is the guidelines in 2021 from the European Society of Cardiology. All of us know the guidelines. When the ejection fraction below 35, a wide QRS complex, left bundle more than 130 or non-left bundle more than 150, you should implant the CRT to decrease mortality and decrease hospitalization as well. And this is the clear indications, as Professor Lamia showed in the previous presentation. It's a class 1 in the left bundle more than 150, or it's a class downgrade of the class if 130 to 150. And this is very clear, and this is, as the guideline said, and this is the normal practice we do. Whether it's a CRT or CRT-D, which is a defect in the left bundle area pacing, probably we cannot implant a defibrillation and we need to implant another lead for defibrillation. And this is very important point. With the left bundle area pacing, up to this point, you cannot place a defibrillator lead in the left bundle area, and you need to put another lead if you are gonna put a CRT-D for this patient. And we have more than 20 years of evidence. More than 20,000 patients with a CRT showed improved in the ejection fraction, improved in the decreasing hospitalization mortality. And this goes for the patients with advanced heart failure, New York Heart Association class 3 and 4, and even the patient with the mild heart failure class 2 as well, and with indication of pacing with just impairment of the ejection fraction. These are all the trials, and all of them were positive trials showing that if you implant the CRT in the correct patient, a proper selection of the patient, this will lead to decreasing mortality and hospitalization and the improvement of the ejection fraction. Then to go to the left bundle area pacing, and a crucial point again, you should differentiate between his bundle pacing and left bundle area pacing. The his bundle pacing is the most physiological form of pacing because you try to capture the conductive system from its origin, from the his bundle, and then propagate along the both bundles and the Purkinje fibers, getting the narrowest QRS complex, nearly native QRS complex. But we have problem with the his bundle pacing, and I think now, in my opinion, it will fade because it's difficult to implant, very high thresholds, and then we have a problem with the thresholds, a problem with the extraction, a problem with the sensing. So nowadays we have the left bundle area pacing because it is easier to implant, proper threshold, and I think if we are gonna to do conductive system pacing later on, it will be a left bundle area pacing, not his bundle pacing. And this is the evidence we have. We have the MELIS registry. This is the largest or the most recent registry from the European Society of Cardiology with about 14 countries, and the number of patients is 2,500 patients. But these are not heart failure patients. This is not the same patients of the CRT. So we have only something like 27% only of these patients are heart failure patients. So we are talking about something like 500 patients from this large registry, and only 22% of them are left bundle branch block patients. So this is the largest evidence we have. And again, the success rate or one of the predictor of failure to implant a left bundle is presence of heart failure. So it's not easy to implant a left bundle area pacing in patients with heart failure. This is important. One also predictor of failure is the broad QRS complex. Getting a broader QRS complex like the indication for CRT is a predictor of failure for the left bundle area pacing. Depressed ejection fraction and heart failure, all of these are the indication of the CRT, and all of these are predictors of failure of the left bundle area pacing. Then we have the complications or the non-complication up to this point. We have intra-procedure intraventricular septum perforation, delayed perforation, acute chest pain, acute coronary syndromes, coronary artery fistula, lead dislodgement, higher threshold, non-screwable leads, and there is no stroke up to this point. And then we have the problem of the extraction. And this is a picture of a perforation of the interventricular septum, a delayed perforation with loss of the left bundle area capture. Another important point that we don't know whether the disease will progress in the area where you implant your lead in the left bundle or not, because it's a disease of the left bundle, and you may expect a propagation of the disease later on the left bundle, and then you will lose the capture completely. So what we are missing: long-term data, prospective randomized trials, evidence in heart failure and mortality reduction. And as Professor Lamia showed, the most recent HRS guidelines for the physiologic pacing in patients with heart failure, it indicates that CRT is a class 1. CRT is a class 1 indication because it has a substantial greater evidence than available to support the conductive system pacing. This is a statement in the guidelines. So we should implant a CRT because we don't have enough evidence to implant a conductive system pacing in patients with heart failure. Again, as an alternative to the CRT, or after failure of CRT implantation or inadequate response, you should go to a conductive system pacing rather on. And this is the indication. I think Professor Lamia showed it nicely, that we should implant a CRT in the patient with heart failure unless we have a problem with the CRT implantation or improper response. And as you can see, there is no class 1 indication for the left bundle area pacing or conductive system pacing in patients with heart failure. So the green is class 1, which is the CRT with biventricular pacing, and the yellow and the orange is either class 2A or class 2B, and this is after failure or improper response to the CRT. And this is again the same guidelines. You can see that the yellow, the class 2A, is for his bundle area pacing, his bundle pacing or left bundle area pacing, as an alternative for CRT in case of improper response or the CRT cannot be achieved. But the CRT is still class 1, still indicated in the patients with heart failure and wide QRS complex, as you can see. So we can talk about left bundle area pacing as alternative therapy. It's like meditation or yoga or acupuncture. So you can use it in the same way. And it's the second choice, the second best, the second rate, the second class. It's minor, inferior. I doubt it's inferior, but I mean, I don't have long-term data. And this is to summarize everything. We have a randomized control trial for the biventricular pacing in heart failure patients with a positive findings in all of your patients. His bundle pacing versus biventricular pacing, still we have some evidence, small evidence. There is no long-term data. There is no randomized trials. Again, for the left bundle area pacing, still we have the same. We have some data. It's non-conclusive. It's not long-term. It's not randomized. So still, CRT is the standard of care in heart failure patients with reduced ejection fraction, left bundle more than 150 millisecond. Left bundle area pacing is promising physiological modality to maintain physiologic conduction, yet several points are missing. Large prospective comparative data are still missing to modify the guidelines. Thank you.